Alrighty, good afternoon. A couple of quick things. If you guys are working on your EALs on your phone, I need you to go into a computer or laptop or something at some point and go into each one of those chapters that you've done so it'll transfer that grade over into the grade book. For some people, it's showing that like you hadn't even started some yet. So just make sure that you do that like at least once a week or something. Like when you go to get on and take your quiz or whatever, just click through those chapters real quick so that it'll transfer those over. What else? We have a midterm this week on Friday. We're going to try to knock out as much as we can of the general surgery lecture here today. Then I'll compile that file and send it to you guys. As soon as it's done doing all of that, then I'm going to make another video that finishes off general surgery because you guys are going to need some of this information for the midterm. I created a study guide for the midterm, and then I've already sent it to you in your email through Canvas. Hopefully all of you have that now. It's a 100-question test. Everything that's in that study guide, if you study everything that's there, you'll be able to walk this test, no problem. I'll release the code for it tomorrow. There's a code to it. It's not Star Wars themed, unfortunately. But I think it's one I don't think you can pause during it. I don't think you can like stop and come back. So make sure you allot yourself a good enough time to take the test. Any questions on any of that? Alrighty. Let's jump into general surgery. We're starting to get into the meat of why you guys came to school, right? To actually get to do surgeries in some of these different services and things like that. Like I've said before, the key to these different services is really knowing your anatomy. It's going to help you a lot into understanding what's going on, why you use certain instruments versus others, why you use certain supplies versus others. Because if you understand the anatomy that's going on, then you'll understand why we're using what we're using. The majority of general surgery takes place in the abdomen. General surgery is typically the surgery of the digestive system. And a lot of your digestive system is housed in the abdomen. Some of the things to know as far as your anatomy is the abdominal wall and its layers. Right? The GI tract itself going from the mouth all the way down through the anus, and the different layers of each of the structures, like the layers of the esophagus, the layers of the intestine, that kind of thing. You have your biliary system, biliary kind of bile, right? That's why the gallbladder is associated with it. Liver is also included in that, and all the structures of like the common bile duct, the cystic artery, all encompassed within that biliary system. You got to know the spleen, right? Where it lives in the upper left quadrant of the abdomen, and what its function is, right? It's a reservoir for like old blood, and it's part of your immune system. So, in understanding then what kind of maybe complications the patient may have during surgery, after surgery, those kind of things, things that we would maybe need to be on the lookout for. You've got the pancreas, which is just below your stomach. It's in the upper part of your abdomen, right? Kind of spans a couple of quadrants, the right and left, or right and left upper quadrant. And it sits transverse or horizontal, right? And you'll understand what its function is, right? One, through insulin and insulin release, it's helping control blood sugar levels. And then it has a secondary function. So make sure you're reviewing all of these different organs, right? Hepatic being liver, right? And then sometimes they do like breast, non-cosmetic type stuff, which we've been doing, like the breast biopsies, mastectomies, things like that, typically for cancer related when they're up working on the breast. These are 4 quadrants. Right? I also broke it down into the 9 regions, but your 4 quadrants, you can see those are like in the print on there. You got your right upper quadrant, left upper quadrant, right lower, and left lower quadrants. So you're basically just dividing, putting a plus right through the belly button, and then everything that's in the right upper, right lower, left lower, and then you gotta know what organs live where, right? And according to those quadrants, and then also the 9 regions. And a lot of this should be review from anatomy, right? When talking about the quadrants and the religion and the regions here. But you have the right hypochondriac, epigastric in the middle, then the left hypochondrium, and middle. So it's like playing tic-tac-toe, right? With your belly button being the center square. That's the umbilical region, right? And then to the sides of those are your flanks. And then below your belly button is suprapubic. And then to the right and left are your iliac regions. So the way to kind of remember it is to memorize those 3 middle. And then you can work off of to the sides of those, right? So know that umbilical here, right? Epigastric, epi meaning on top of, gastric being the stomach. So that one's up top here. And then suprapubic means superior to the pubis area. So just above the pubis area, right? And then you know your iliac crest is on either side, and then these are your flanks. And then you just got to remember hypochondriac for the right uppers, right and left upper. Tissue layers of the abdominal wall, right? So know these, it's skin, right? We're going outside to in, and you have to know it inside to out as well, because sometimes there's questions on that AST or the CST exam that will they're testing whether or not you really know the layers, and they may ask you, hey, this layer comes between the peritoneum and the muscle, or this is between the muscle and the skin layers, things like that. So definitely know these in their order. Yeah, so when they're closing, that's why they typically use the O or number 1, like Vicryl or the PDS or Proline or something strong. They change the type of suture that they use dependent upon how much risk the patient has for infection. So, and if the doctor's been seeing kind of a rash of infections, surgical site infections over and over again, they may switch up. So typically, if you suspect there's going to be an infection, you do not want to use a multi-filament suture, because with all the nooks, because remember that's braided. Those multi-filaments are braided sutures, are twisted around one another. So if microbes, there's a lot of nooks and crannies that those microbes can adhere to and kind of fester and grow from. So typically, if you suspect that you're going to have a potential for infection, you want to use something monofilament. If there's an infection already there, then the best suture material to pick is surgical steel, because and that one's monofilament, but it's steel. There's nothing for the bacteria to feed off of or anything like that, so they're not going to grow on surgical steel. We don't typically use it to close wounds with. Most often, the surgical steel is used to close the sternum during open heart procedures after we've cut the sternum in half. When we're closing up, we'll use those surgical steel to bring and hold that bone together. But you will see on the CST exam, there'll be a question somewhere in there asking about which of the following is the best suture material to use in the presence of infection or something like that. If surgical steel is one of your answers, that is always the best answer, because it's what's known as an inert substance. It's not going to react with the tissues, and it's not going to react with the bacteria to spread an infection. Incisions, definitely know these and what they're used for. Your midline incision, when doing anything open abdominal, is your typical general surgery abdominal incision. It's right down the middle. They do not go through the belly button. They'll actually curve and go around it. When they draw, it'll be the straight line down until they get to the belly button, and then they'll kind of do a little arc or half circle around it, and then continue the line down to the pubis region. The reasoning for that is because you can't really suture the belly button back together if you split it in half. So, and it's got umbilical vessels and ligaments and things that are coming down and kind of adhering to the abdominal wall in there. So to cut right through the middle of it, now you're inviting an umbilical hernia in the future. Paramedian just means it's still a straight vertical line down, but now it's off center from midline. So it's halfway between the patient's flank or side, right, and the midline. So you're still cutting just straight down. Subcostal means below the rib. If you are doing a subcostal incision on the patient's right side, that is known as the Coker incision, spelled just like the clamp that we have. Coker incision. On the left side, it's just a subcostal, left subcostal incision. You can do flank incisions, typically for kidney surgery, along the patient's side, make a horizontal incision that way. Inguinal, this is in kind of your groin area where your leg meets your trunk, kind of just above that. Typically used for inguinal hernias or femoral hernias. McBurney's incision. Most of you should know this one. We've been doing McBurney's incision while we practice on the appendectomies. Rocky Davis. Make sure you look that one up. I want you guys to actually crack your book a little bit. Mid-abdominal transverse. This is a horizontal incision across in the mid-abdomen. Because if you're going lower, that lower transverse incision, that's that phanastile incision that's typically used for C-sections. If you're doing a mid-abdominal transverse, you may be doing an abdominoplasty, where you're going to mobilize like the skin of the abdomen and then pull it down tight, and then cut off that excess and then resuture the remaining. So now it makes it look nice and tight and flat. That's how they do abdominoplasties. Inguinal, the inguinal area. So there's a spot inside your body, right in your inguinal area, that is known as Hesselbeck's triangle. And the three sides of the triangle are made up by your rectus abdominis muscle, the inguinal ligament, and then the inferior epigastric vessels. So Hasselbeck's triangle becomes very important because that's where your inguinal canal and all that is. And within that inguinal canal is the spermatic cord. And within that spermatic cord is everything you see listed here: the cremaster muscle, the spermatic fascia, the genitofemoral nerve, the ductus deferens, which is like your vas deferens. That's where your vas deferens comes to a head so that sperm can be ejaculated. Your lymph vessels, your testicular vein and artery, so the actual blood supply to the testicles, is all within that spermatic cord. The reason that this triangle is important is because whenever you get a hernia in the inguinal area, there's two different kinds of hernias that you can get. One is a direct hernia, and the other one's an indirect hernia. If the hernia is going right through that triangle, right through Hasselbeck's triangle, and poking out of the abdominal wall through that triangle, it is known as a direct hernia. If the hole in the abdominal wall is anywhere outside of that triangle, then it is an indirect hernia. It's the easiest way to determine between the two. Typically, the inguinal hernia is most common in males, and the femoral hernia is most common in females. They occur at the same location. Just for the femoral hernia, there's no spermatic cord involvement because it's typically in a female. And for a male, they wouldn't classify it as a femoral hernia. They would call it an indirect inguinal hernia. Next on the list there of hernias, you have an incisional or ventral hernia. These are going to be big hernias on the abdomen. I think some of you have probably seen Mr. Ortiz's that he has kind of like right here in the middle. Right? That would be a ventral hernia. The other reason they call it an incisional hernia is that it's a hernia that's developed after the patient has had some kind of surgery, some kind of abdominal surgery. So we made an incision first. We did our surgery, we closed them up, but we weakened those muscles in that abdominal wall, and the contents within the abdomen, intestines and omentum and all that, over the years, found a way to work its way through those holes and start to push out of the abdominal wall and be just under the skin. Umbilical hernias happens at the belly button, or umbilicus. A splagellin hernia happens in between the muscle layers of the abdominal wall. So it kind of pokes out of the abdominal wall and then starts to go in between the muscles. Very difficult to diagnose. And then you have your strangulated or incarcerated hernias. What this means, and it can be one or the other, strangulated or incarcerated means the same, is that there is now bowel involved. Could be small bowel, could be large bowel, but that is the actual content of the abdomen that is poking through the abdominal wall. And for any of you who have ever stuck your head through the rails of the like staircase or something like that, and you found it easy to stick your head in, but to come back out, you can't, right? So somebody has to come and cut the little pieces or whatever so you can get out. It's the same thing with the strangulated or incarcerated hernia, that the bowel had enough pressure behind it to push through this little tiny hole, and it made it. But now the hole's too small for it to come back in, and it starts to pinch it off and squeeze it off, strangulate it, or incarcerate it, lock it down, right? Well, what do you think is going to start to happen to the bowel that's getting choked out? it's cutting the blood supply off to it, it's going to start to die. It means we have to get in and do surgery, because we may even need to do a hernia repair with a bowel resection. So a lot of times they'll schedule it as a strangulated hernia or incarcerated hernia repair or something like that, and that way you were already anticipating that we may have to take some of the bowel. Right? If we catch it early enough and we can get that bowel to pink back up, then we don't have to resect anything, but might have to. Your case planning with regards to general surgery, is it an open procedure or is it minimally invasive? Are we doing this laparoscopically? Right? It's going to change up the instrumentation and the equipment that you need. If you're going to do it laparoscopically, you need scopes, camera, light cord, trocars, something to the Varus needle to insufflate the abdomen. Right? If you're doing it open, well, then you need your major tray, a lot of laps, some ties, a big suture to close the fascia, all those kinds of things. Right? What position is this patient going to be in? Right? Are we doing a low anterior resection, or resecting a part of the sigmoid? Okay, are we going to do a reanastomosis, or are we just going to create a colostomy? And a lot of that's going to be in the naming of the booking of the procedure. Exploratory lap, sigmoidectomy with colostomy, with creation of colostomy. Now okay, that's what we're doing. We're not going to try and reconnect this bowel and completely close this patient. So there's no need to put this patient in lithotomy position, because we're not going to use the EEA stapler to come from below. Right? What instrument set do I need? Open versus minimally invasive. Do I need the laparoscopic tray? Do I need the major tray? What suture? Am I just going to be closing skin, trocar sites? Or am I going to be actually closing full, fascia and sub-Q and then skin and all that? I was trying to miss that question. So as far as the preference card goes, if it's an open procedure and it's booked that way, then you're going to get the open preference card. So it'll have everything that you need on that preference card. If it's minimally invasive, then you'll get the minimally invasive or laparoscopic preference card. And it should have all that stuff on it too. But let's say it's you're on call or something like that, and it's an add-on. Typically what will happen, if you're working at a place that doesn't have like an overnight or a graveyard shift, and just the people who are on call, you got to come in and start picking your case. The nurse has to go and like book it in the computer and all that system just to get that case card or the preference card to print out, while you're already in the back picking stuff. And okay, this is open, so I'm going to need all this open stuff, or this is laparoscopic. Let me stay with laparoscopic side until I get the preference card to get a little bit more particular things like the suture we're going to use. Are we going to use mesh? And in hernias, because in hernia repairs, you can do it open or laparoscopic as well. Right? And that's where the mesh comes in. What kind of mesh are we going to use? Do we need one that's geared more for laparoscopic that we can kind of fold and roll up and fit into the trocars? Or is this a really big hernia and we're going to be using this huge piece of mesh and we're doing it open or something like that? So for a does the card show? No, your preference card will not give you any kind of recommendations on instrumentation. They'll not tell you what like the surgeon uses or anything like that. All it is like you guys have seen in lab, is basically just a list of supplies. And you may get like a little note or something in there that lets you know that the doctor is like left-handed. But as far as like the little nuances of like, oh, he likes these particular type of DeBakey forceps or whatever, he only likes, gold handled clamps or something like that, that's not going to be on there. That's something that you learn as you work with that person, and then your preceptor should also be cluing you in to those little nuanced things. When doing an inguinal hernia repair, open, you'll have a half-inch Penrose drain on your table. You will open that to start with. It's not because they're going to put a drain in at the end of the procedure. They're going to use that Penrose to wrap around the spermatic cord, and they're going to use it kind of as a retractor to help hold it out of the way, because there are a lot of delicate nerves and blood vessels and things going through there, and because it is such a vital of vital importance, you don't want to put like an actual retractor on it and put too much strain and stress on it and things like that. So that's why we use the Penrose. It's a much more delicate kind of retractor for it. And it's the only time you'll really ever see the Penrose used that way. So what I typically do with that Penrose is I'll take a Kelly clamp and I'll clamp it to the end of the Penrose, and I'll put the whole thing in my saline bucket and just let it sit there until we're ready for it. They're going to want it wet with the saline so it slides around the tissue easier and helps keep the tissue moist. So I'll show you guys this too in lab, but it's really easy. And the reason I put the Kelly is because as soon as they wrap it around it, they'll take the Kelly and clamp off the two ends so it doesn't slide off of it. And then they can use it to kind of pull and then clamp those two ends to the drape. So then the drape will kind of help hold the Penrose as well. But just know that the Penrose is used to retract the spermatic cord. Femoral hernia, kind of the same issue there in that inguinal, but like I said, typically more for females. The reasoning behind that for males, the reason that our inguinal wall and everything like that kind of deteriorates and we get hernias in that area, that's a common place to get hernias, is we do a lot of straining with like lifting and things like that. And it can also be genetic, that you're kind of you already have kind of a weak wall in that area. For females, it's childbirth, or that again, kind of genetic predisposition to it. But for them, that's the straining and that's the stress and everything that happens for them in that area is pregnancy and childbirth. But it's just we're trying to strengthen up that inguinal muscle area and provide some strength to the abdominal wall there to prevent those contents and like intestines and things like that from poking out and not living where they're supposed to live. I talked about this, right? The incisional ventral hernias, right? Usually through a previous scar, previous surgeries. Can even happen for laparoscopic procedures. That's why if you use a trocar that's 10 millimeters or larger, then you're going to put at least one stitch into the fascia to close it up, or you could end up with a trocar site hernia. Those are becoming much and much more prevalent because we do a lot more things laparoscopic and stuff like that now. So umbilical hernias can be relatively small, can happen to children. Some babies are born with an umbilical hernia already. Some of them are born with an umbilical hernia and they don't require surgery. And for some, it can be kind of a normal thing. And then after a few months or so, the hernia retracts and the abdominal wall closes and seals itself off. So usually in newborn infants and things like that, it's something that they just watch. And then if it goes, if it doesn't go away by a certain age, then they can take care of it because they don't want, any intestine or anything like that ending up in it and causing some kind of strangulation or something like that. The other demographic that has a kind of a predisposition for this is the obese, right? The overweight, things like that, because you are putting a lot of pressure on that area, and especially the umbilical area. Everything's kind of ballooning out and putting pressure there. So you're putting pressure up against that abdominal wall, causing a weakening in that area, and then boop, little hernia. Well, splagellin. Oof. But it's going between like your abdominal layers. So you could have it between like the peritoneum and the fascia. And because it's not coming straight out, where it's like when you see somebody with a hernia, right, they got like this big bulge somewhere because those abdominal contents are spilling out of the abdominal wall. Well, with these flagellin hernias, they don't come straight out. It kind of tunnels its way underneath a bunch of stuff, and you get these abdominal contents, instead of them spreading just outward, they're just spreading, widening out and going in between the layers. If left untreated, you could have I mean, your intestines could basically be like right underneath your abdominal muscle and not in the abdominal cavity, just spread out throughout the whole thing. So if you took, like one, good hit or got into an accident, you could rupture all of that, those intestines that are sitting just right underneath there. So again, very hard to diagnose because of the fact that they spread horizontally rather than straight out. Much harder to see, and the patient could be having just weird kind of pains and strange bowel movements and things like just irregularities, stuff like that. And they do a CT scan and all that, and they're not. Everything looks fine because those hernias are spreading out kind of in line with the abdominal layers and those tissues. So they don't really pick it up on like CT scan, and they may see something a little strange and be like, "What is that?" and causing further investigation, but it may take them a while to diagnose it. It's not a very common hernia anyway. So the anatomy, right? Remember that digestion begins in the mouth with saliva and the breakdown, the amylase, those enzymes and stuff like that. Then the food bolus, or the big chunk of food that you've swallowed, goes down your esophagus, right? Down through into your stomach. Through what part? What's the connection between the esophagus and the stomach called? The cardia. So right where the esophagus and the stomach meet, that area is known as the cardia. And there's a sphincter there that opens and closes and allows, little bits of food in at a time or whatever. That's called the cardiac sphincter because it's right there next to your heart. And then from the stomach, we go down into the small intestine to the large intestine, rectum, and anus, right? Remember that the terms anastomosis is bringing back the two hollow structures, connecting them back together, whether that's end to end or side to side or end to side. Right? A resection is the opposite. It's taking out a piece of something. Could be a piece of a bone, organ, different organ, a piece of the intestine, whatever it may be, a biopsy. That's a resection. We're taking you have to have something that's continuous, and you're just going to take a section of it out. And then reanastomose those two ends.
Mr. Logan.
Yes.
What was the name of that sheet that you said that was part of the bottom portion of the stomach? You said Odin or Om?
Coming up right now.
Oh.
So this part right here, this is the esophagus. And then where it connected, that's the cardia. And then this big hump up of your stomach that goes up like this, that's the fundus. And then this is the body and the antrum of the stomach. Well, connected to this and this side in here, this is the lesser curvature of the stomach, and this is the greater curvature. So you have bigger curve, greater curvature. This is where the omentum connects to. And it's just like this big drape or curtain that hangs off the stomach and kind of covers over all the rest of your abdominal contents. It's kind of like a bubble wrap. It's just like a fatty sheet that hangs over everything just as a kind of a layer of protection. It doesn't provide a huge amount of protection like your rib cage would, right? Somebody punches you in your rib cage. Yeah, it's going to hurt you a little bit, but they're also punching against bone. They're not going to really, do that much damage to an organ underneath. But if you get hit like in the solar plexus, right, or right in the abdomen, it's going to hurt for a lot longer because you don't have anything that's really protectant. And then after the stomach is where we're going to connect to the small intestine, right? And this is where you remember your DJ ileum, right? Duodenum, jejunum, ileum. And the ileum is what connects to the cecum, and that's part of the large intestine. You got your liver up here, spleen, and this is your pancreas here in the middle. So this is kind of how everything is arranged in the abdominal cavity here. And then right underneath the liver here is your gallbladder with the cystic duct and the common bile duct and everything coming down and connecting here to the duodenum. And then the pancreas has its connection right here in the duodenum as well. So what does the small intestine do? What is its function?
Absorb nutrients.
Right. Yes. So this is where we're absorbing vitamins, nutrients, all that stuff is happening in the small intestine. Little bit of water, right? Because it's going to follow a little bit of those electrolytes and things that you're absorbing because of concentration gradients. But the large intestine, its one and only job, well, not one and only, but its main job is to reabsorb water. And then its secondary job is to expel waste. So by the time the fecal matter gets to the large intestine, you've absorbed all the nutrients you're going to get out of that. Whatever food you ate. But always remember DJ ileum, duodenum, jejunum, ileum. That's the three parts of the small intestine. They don't get into the large intestine? That's not nice. Okay. And we've covered kind of the large intestine in lab a little bit, but remember it starts at the cecum, and then hanging off the cecum is the appendix. You're going to go up the ascending colon, and then at your turn, also known as the hepatic flexure, then you're going to go across, or the transverse colon, and then you're going to turn again at the splenic flexure, and now you're going to start to go down the descending colon, and then where it makes that curve and turns into like that S, that's the sigmoid colon, and then you get into the rectum, and then the anus, and you're out. So, and the rectum and the anus are pretty fixed in that spot. You can't really free up a whole lot of tissue around them and do that's what's known as mobilizing, is when you're freeing up the tissue that's around it that kind of attaches something in its spot, and now you can kind of freely move it a little bit. You can kind of pull it into a different direction. The rectum and the anus, there's not a lot of tissue in there for you to be able to pull. So if you're doing some kind of sigmoid resection, you're going to have to make sure that there's enough. Well, we won't have to make sure, but the surgeon would have to make sure that there's enough colon left to be able to stretch it down and reconnect down here. Otherwise, that's how you end up with colostomy, a permanent colostomy. Some
Is there
diagnostic procedures. Oh, yes, go ahead.
is there a certain number, like percentage wise, of how much of the largest intestines need or that can come out until like it is where a colostomy situation? Like, can you take out, like say 40 or 60% of the ascending all the way to let's say like 10% of the descending colon and just you like crossover there?
Um, I would venture to say that that's too much. I don't know like exact numbers or percentages or anything like that. But based on kind of experience, anytime we seem to do a hemicolectomy, where you're going to take half of the large bowel, we always gave the patient a colostomy. And sometimes the surgeon would say this is just temporary. We're going to come back in a few weeks and do a takedown and reconnect them. And other times, they would say that they have it for life. And I never really asked as to what the criteria was for why they decided one way or another. So I'm not 100% on that. I wouldn't be able to tell you why they make their decision. I know that if you were to take, because like what you were describing was like taken from like here, right,
Yeah,
to like down to like about here,
yeah.
and then trying to bring the rest of this over to connect to this. It, because you still have to have so much of the large bowel left to still absorb uh, enough water, and that's why I don't know how much you need left in order for it to still be kind of a viable thing.
Gotcha. And there's no such thing as like a large bowel transplant or anything like that, right?
Not that I've seen, no, but then again, um, anything's possible. I mean, they're doing face transplants now, so I'm sure one day in the future there'll be like brain transplants and all kinds of stuff. Hmm. I don't know if I want somebody else's bowels though. I think I'd rather just call it a call it a life at that point. But some diagnostic procedures for GI surgery. We can do, X-rays, CT scans, MRIs. We can do them with barium swallows, where you give the patient something to drink that has like barium in it. That's going to show up in these imaging studies, on X-ray or on CT scan or something like that, and then they can watch the track of the intestine and how it's pushing things through. Most of the time, it's going to show them, their blockages or strictures, areas where the intestine's like really narrow and tight or something like that. And that may be causing pain because when fecal matter gets to that spot, it has to your peristalsis has to work harder to push it through that tighter hole. So it causes a little bit of pain to you because it's also going to stretch that stricture and stuff like that. So, um, but there's other diagnostic procedures like the endoscopy, right? They can put a scope in and actually look. Typically, if you're doing it electively, you're just doing like a cancer screening. You're making sure that there's nothing in there that looks cancerous or whatever. Um, and if you're having like rectal bleeding or esophageal bleeding or something like that, then they can put a scope in there and help take care of that bleeding, stop the bleeders, or find out what's causing it. Um, Other things that they look at is, they look at your blood in chem panel or metabolic study, right? They draw blood from you and run it in the lab because that can give them clues as to things that are going on with the GI system. And then ultimately, they can also do a physical exam where they put hands on you and like touch and put pressure on the abdomen. Does it hurt here? Does it hurt here? Uh, and they can also auscultate or listen with the stethoscope. Uh, and listen to bowel sounds. Right? They can, if they're like listening up here, they'll start down at the cecum, down in the right lower quadrant, and listen for bowel sounds, and then just follow those bowel sounds up the ascending, over the transverse, and down the descending. But let's say they're listening, and they're hearing them, and then they get to the transverse area, and they're not as pronounced as they were, and they're like, oh, and they get down into the descending area, and they don't hear bowel sounds anymore. Could mean that there's a blockage, and that peristalsis isn't working anymore. It's not pushing anything along anymore. So, pathology, right? This is, do we have a blockage? Do we, is there, is it like Crohn's disease or irritable bowel syndrome or things like that? Things that we need, and this comes into play with us kind of understanding if we're going to end up with an ostomy or not, right? If the bowel where we're trying to reconnect to is too inflamed and just looks real angry, or the side that the obstruction was happening on, if it's too swollen up, then we need to allow that bowel kind of time to calm down and relax and come back to normal before we can reconnect those back up. So we got to give them a colostomy in the time, in the meantime, so that they can still make waste and things like that. Some things we got to think about. These are for more of your open type procedures and stuff. Thermal regulation, right? We're opening this abdomen up. It's exposed, to the outside, to the coldness of the operating room. So we definitely got to have warming blankets on the patient, covering everything else that we're not working on. Compression devices. These are like the TED hose and the SED machines, the sequential compression devices, to prevent any kind of pooling of blood in the veins and things like that, causing a thrombosis. What position are we going to go in? What instrument sets do we need? Right? Are we going to be, doing any kind of bowel resections? Right? Are we just doing a license of adhesions? Do we need the stapler? Do we not? What kind of sutures are we looking at here? Are we talking about, the silk ties and the #1 Vicryls and all that kind of stuff? So all that's in part of your case planning. Remember that this is always the stuff that's going through your head, right? What position is this patient going to be in? What anatomy are we working on? What's the best way to get to it? What instrument sets work with, best with that anatomy? That kind of thing. It's always starts with your anatomy. Anastomosis, right? The staples get used pretty much all the time now for doing a reanastomosis of bowel because it's so much easier and so much faster. And it helps to prevent infections because you don't end up with that spillage of fecal matter or anything like that. And when we do finally poke a hole, in those two ends to reconnect them, it's very controlled, right? The little small holes, we're getting those staples in, getting it together. We're not, hey, we did this one staple. Okay, now let's, do some other things and leave this open. As soon as we start doing the anastomosis, we see it to its end so that we don't have any of that spillage. But we do take precaution and, putting our towel down. We understand that some instruments are going to get dirty and things like that. So then we employ our bowel technique. A few different ways that we can go about doing this, right? We've kind of talked about this already. Like with the breast biopsies. You don't want to reuse any of the instruments that were used to touch the tumor with, or while the tumor was still in, because those could have little cancer cells on it. So you, off to the side, separate your clean instruments that are going to be used after we take the specimen out, right? Or like we've been doing for the appendix and the X-laps, right? You lay a towel down. As things get dirty, they get put on that towel and they get removed. You can use 2 Mayo stands and have like a clean Mayo stand and a dirty Mayo stand. I would definitely keep them far away from one another. Like the Mayo stand you start the procedure with is going to become your dirty. You have that one up. You have your clean one over next to your basin at the end of your table. So then they can just take all that dirty stuff and put it on top of the Mayo stand. And then when it's time to get rid of the dirty stuff, you just wheel that whole Mayo stand over, change your gloves, grab the clean Mayo stand, and now bring that into place. And then give everybody their new gloves or whatever, and then proceed from there. And now that dirty one's sitting over there for the nurse to take care of and go through for counted stuff. And then you've got your clean one already ready. But again, before closure and clean out and all that, we got to change. Typically, it's always the gloves are changed. But depending on what hospital you work at, you may or may not change out the gown. And depending on how much fecal matter and stuff there was, if you got a bunch of stuff on you and on your gown and everything, you're definitely changing it out. Definitely changing it out. These are ones that are be typically done in endoscopy. The esophagogastroscopy, looking at the esophagus and the stomach. So you're going in through the mouth. Duodenoscopy, same thing. You're going in through the mouth, but now you're specifically going down to look at the duodenum. Like colonoscopy or sigmoidoscopy, now you're coming from the other end. Typically, if you're going to be having a colonoscopy or a sigmoidoscopy, those patients are given an enema. Usually they give it to you that you do yourself at home before you come in for your procedure. And you're not allowed to eat or drink anything, so that there's no fecal matter in your bowel when they're trying to run this camera through it. Because then they got to go through some big piece to be able to see, right? And of course they don't want all that coming back, because putting anything up that way just causes like a stimulation that makes it all want to come out. And none of the GI doctors want to deal with all of that in the bed. If typically what'll happen is if you didn't do your enema or didn't do your clean out or whatever, they'll put the scope in and come across something and then be like, oh, they didn't follow instructions. This case is canceled. And they'll immediately pull the camera out and walk away, take their gloves off, hand the camera to you, take their gloves off and walk away. Because it's too much of a struggle for them to do what they need to do. Inspection of the duodenum, right? Inspection of the colon. And then, of course, through each of these, the esophagogastroscopy, the duodenoscopy, colonoscopy, sigmoidoscopy, they can take little tissue biopsies. Typically, if they're just looking, those are diagnostic procedures. If they do take any kind of biopsy, it becomes an operative procedure, and you guys can put them down on your case logs when you're in clinicals as a second scrub general surgery case. So you need, I think, 10 of those as part of your requirement or whatever. Laparotomy, this is otomy being making an open into the abdomen, is what it means. Typically, they're booked as an exploratory laparotomy. It's kind of a blanket term. It gives them, it's kind of like a saying, we're going to do a knee scope with repairs as indicated. You say exploratory laparotomy, it means we're going to go look around in your abdomen and then fix something that's not right or something that's broken. Right? Or they can use it to confirm a diagnosis that they came up with through other like imaging studies and blood work and things like that. They say, hey, we, based on the things that we've seen through X-ray and what your blood work is telling us, is that you have colon cancer. But we're going to go in, and then when we actually see it now, it gives us that confirmation. Yep, this is definitely colon cancer or whatever.
Mr. Logan.
Yes, sir.
When they find like they got colon cancer and whatnot, are they also doing the whole markers for as far as tumor markers and everything for the lymphatic system, and then kind of pulling those out also, or is that kind of just like, all right, find the colon cancer, get the colon cancer out, and then we'll worry about the lymphocyte stuff back later?
Yeah, typically it's like for the colon cancer, it's just let's remove uh, that section. That's the cancer. Unless they saw something through blood work or something that tells them otherwise, they typically don't touch the lymph nodes.
Okay.
Not for colon cancer anyway. But I mean, each situation is kind of unique to that patient and what's going on with that particular patient at any given time. So you can take lymph nodes. It's not never done, but it's rarely done.
That's just more on a metastasis basis.
Yeah, usually, yeah. And
Okay.
you'll see that necessarily won't be a general surgeon. That'll be an oncologist. So if you're working with the oncologist, then you're doing like the stagings and the tumor debulkings and taking lymph nodes and doing more radical ectomies and things like that.
Gotcha.
So now I think we're going to start getting into a lot of surgical procedures here. And we will start kind of up in the upper digestive system, in the esophagus. So a diverticulum, if you think about like on the bowel, the little bulges on the outsides of the bowel, those are like diverticulum. Whenever something kind of expands that out or kind of gets lodged in there and doesn't heal up, or you can even get like a varicose vein in one of those. Same thing can happen in the esophagus, or you kind of get a bulge out to the side of the esophagus. And then as food comes down, instead of going down and into the stomach, it dips off to the side and goes into that diverticulum. And that just keeps growing it and stretching it and stretching it until either the wall of the esophagus ruptures, and now you're bleeding out into the spaces around the esophagus inside your chest, which is now going to put pressure on the heart, or it doesn't rupture and it just keeps growing, and now it's pushing all the other tissues in their spaces and kind of collapsing and putting pressure on them that way too. So the way that they do this is like the diverticulum kind of bulging out here on the sides. And they go in and they just remove that section and then reanastomose the two ends. They do some mobilization and free it up and bring it back together. But remember, just like with the colon, your esophagus can only stretch so far. So if you have to take out too big of a section, and this is typically for like esophageal cancer or something like that, where you have to do like an esophagectomy, then we need to put in some kind of implant or cadaver tissue or something else that's going to now act as the new esophagus. But now we're moving down. We get down. We're closer now to where the esophagus and the stomach meet at the cardia, right? Or the gastroesophageal junction. And now we're going to be dealing with patients who have GERD or gastroesophageal reflux, right? Stomach acid is coming back up through that cardiac sphincter and going back up into the esophagus and giving you that heartburn, right? You're like, ugh, oof, oof, right? You can try to take Nexium, the little purple pill, and all that, and then that's what they'll start with first. is they always start with the treatments that are going to be the least invasive. Here, take this pill that'll reduce your gastric acids. And since now, so say this cup was full to the brim, right? Well, if I just barely squeeze the bottom of this cup, it's going to whoop back into the esophagus, right? Back up. It's going to whoop back up the system. Well, if I take this and I reduce it to about half, and then I squeeze the bottom of the cup slightly, it's going to come up, but it's not going to go back up into the esophagus. So that's what those little the pills are supposed to do. But for some people, the pills don't work. So you have to do this procedure, which is called a Nissen fundoplication. Most often now we do them laparoscopically, but what we're going to do is we're going to take the fundus of the stomach. Remember that big bulge that comes up the top? We're going to grab that top and we're going to wrap that around the esophagus and then suture it down. And that helps act as kind of another sphincter to not allow that acid to go back up into the esophagus. It tightens that whole area up. This is also typically done for patients who have what is known as a hiatal hernia. H-A-I or H-I-A, no, H-A-T-I-A-L, hiatal. Hiatal hernia. So this is where, because your esophagus is going to come through an opening in the diaphragm to connect to the stomach. Well, that little opening can sometimes get stretched out and become bigger. And now abdominal contents are pulling up into the thoracic cavity. So you got to pull all that stuff back down and then do the same thing and wrap the fundus around and do a Nissen fundoplication to prevent those abdominal contents from going through the hiatal hernia. But you see, there's that opening, right? And they're taking the fundus and then take some other tissue and wrap it around just to secure it in place. And then you see down here on the bottom, it says a 52 French bougie or a 52 French bougie dilator. Remember, a dilator is just an instrument that is all it's doing is you have a natural opening, and the instrument, the dilator, is going to go in to dilate that opening to bigger. You're just trying to make it bigger. You're going to use those dilators, and the dilators come, like one size goes in, and then the next biggest size, and the next biggest size, until you get that hole to expand and get it open. That bougie is like this big, long silicone dilator that anesthesia will use while the patient's asleep. They're going to put that down the patient's mouth, down their esophagus, just to have the tip poke into the stomach like that, so that it gives them something solid within the esophagus when they start doing the suturing, so they don't accidentally purse string and suture the esophagus closed. What would you think would be a problem if we sutured and wrapped this around too tight?
No food would go down, and then you would choke on the food basically.
Yeah, like you couldn't get anything into the stomach. So your esophagus would be piling up with food. You'd be getting, you wouldn't be getting any nutrition, right? Because you are eating, but you're not eating because your body's not able to break any of that down. What happens if we did it too loose? Now we haven't fixed the problem. We haven't fixed the problem, right? If the patient was having that GERD, that acid reflux, and we didn't wrap it around tight enough, too loose, they're still going to have the GERD. If they had a hiatal hernia and we didn't make it tight enough, then those contents may still pull back into the thoracic cavity. We didn't take care of what we needed to. Vagotomy. So this is where you're going to make an opening into the vagus nerve. The vagus nerve is one of your cranial nerves. It is actually the 10th cranial nerve, and it controls, and it's the nerve and the kind of the brain for your entire digestive system. I don't know if any of you have ever heard of somebody having what's known as a vagal response. It's where you kind of and get like lightheaded and you just kind of throw up and pass out. Right, that's known as a vagal response. That's stimulating this nerve, and since it's very centrally located, it just kind of shuts you off. Like your whole digestive system just releases. That's why stuff comes out from here, can come out from below, and you just kind of pass out. The reason we do this procedure is we're trying to reduce gastric juices, the production of gastric juices in the stomach. Right? Usually to treat like a peptic ulcer. Because if we're treating GERD, we're either giving them the little purple pill, right, the Nexium, or whatever kind of gastric juice decreaser that you want to take. Or we're doing the Nissen fundoplication. That's because the problem with those gastric juices building up is causing that GERD, right? Well, if you have a peptic ulcer, that ulcer is in the stomach. So even decreasing the amount of gastric juices isn't going to help that ulcer because it's still bathed in those gastric acid. So it needs to have even less. So you're almost keeping the stomach on almost empty as far as gastric content or gastric juices and acid. A percutaneous endoscopic gastrostomy, also known as a PEG tube. This might be an old reference. Married with Children, Peg Bundy. PEG tube, Peg Bundy. That might help you remember it. But what this is, it's also known as a feeding tube. It's a tube that we're going to put in through the abdominal wall and put that tube directly into the stomach. So now you no longer have to eat through your mouth. Everything gets injected into the tube. So what state of matter do you think whatever you're putting into that tube has to be?
Can you explain that question again? I'm not tracking.
So what state of matter, what are the three states of matter? Solid, liquid, or gas?
Yeah.
So what state of matter does whatever you're putting into that tube have to be?
Oh, liquid.
Liquid, right? So can you eat a cheeseburger through that tube?
No.
If it was in a blender.
Not as a cheeseburger that you know to be a cheeseburger, right? You got to take that cheeseburger, toss it in a blender, liquefy it, and then inject it into that tube so it goes straight into the stomach. Typically for patients who are unconscious, and not just like unconscious for like a day or something like that, but like you're in the ICU, you have a tube in and things like that, because you still need to be able to eat and get nutrition. And we have to have a way to do that. It could be for patients who have had an esophagectomy and are healing from surgery, or something that we did something to the esophagus. We did the Nissen fundoplication, and we need that to have time to heal. Typically, we don't do a feeding tube for the Nissen fundoplication, but it could. Probably be a rare case, but could happen. It's just you're trying to get nutrition to the patient, and you can't do it by the normal mean. So we had to do something else. So we put in also called a G tube. So it could be PEG tube, G tube, gastrostomy tube, those kind of things. And the percutaneous part means that we're going to do it laparoscopically. So we're just going to poke a small little hole in the skin and then feed that tube down and into the stomach while we watch under camera to make sure that it's the stomach we're going into and not like the intestine or the spleen or something like that. And then usually at the end of these procedures, they'll also inject dye directly into the G tube and take an X-ray or fluoro with the C-arm and make sure that they are in the stomach. Yeah, it's not a good time if you're not in the stomach. Gastroduodenal anastomosis. This is connecting the duodenum to the stomach. It could happen that we had to go in and maybe resect part of the stomach, or we had to resect part of the small bowel, or something like that, or we were doing like a Billroth procedure, which we'll talk about in a few slides down. But now you need to reconnect those two. The duodenum is a very specific piece of the small intestine because you have the common bile duct and the pancreatic duct meeting right there in the duodenum, providing the bowel and the pancreatic enzymes to help break down food. So if the duodenum has to be removed, then the common bile duct and the pancreatic duct have to be kind of redirected into somewhere else, so you can still get those enzymes and bile to help break down food. And then, of course, for the duodenum, you may place a drain just for infection purposes to try to prevent an infection. You can do bandings of a stomach for like weight loss surgeries and things like that. What this does is it just puts a band right onto the stomach. I think this has got, yeah, there we go. So see, it's gonna, you kind of pinch off a part of the stomach so that when you're eating, you feel full faster. It forces you to eat less, thereby losing weight, right? You're bringing in less calories, less to be transferred into adipose tissue. So then you should start losing weight, right? Especially if you're burning more calories than you're taking in. That's kind of the key thing to weight loss is you spend more energy than you bring in, and that eventually will bring your body will start burning its own fat sources and things like that for that extra energy that's needed. But these bands are adjustable. So you can make this, we can go maybe a little tighter, we can go a little looser, and depending on how the patient is doing post-op, as they go back for their follow-ups and things like that with the surgeon, there's actually the device on the outside that they can adjust the band without having to bring them back to surgery. And then they may even, because they're going to staple off, no, not for the band. I didn't think they stapled anything. Yeah, they just kind of wrap it over and lessen the amount of stomach that is there. It's when you get into like the Roux-en-Y's, like this one here. This is another kind of weight loss surgery, but much more aggressive. You're actually stapling pieces of the stomach off and removing them. The advantage of the band is that you can go in and remove the band, and now the stomach kind of go back to the way the stomach used to be. If you do a Roux-en-Y or a gastric sleeve, where you're just taking off kind of like that a piece of the greater curvature you're removing with the gastric sleeve, you've now changed the stomach forever. Right? There's no going back. It doesn't grow back. It's just that piece of it is now missing and it's gone forever. But with these Roux-en-Ys, there's a whole different way that they hook up everything here. Let me see if I can expand this a little bit. But you're gonna like staple off part of the jejunum and then bring that up and connect it back in to like the esophagus and leaving kind of a smaller pouch stomach in a different route of the way that the digestion and everything goes. So this is the most extreme version of weight loss. Was initially designed for patients with like gastric cancer and ulcers and things like that, like those peptic ulcers that they didn't have the other surgical procedure for yet to help, and the vagotomy to help lower that acid content. And people were getting these peptic ulcers that were eventually eating all the way through the stomach. So they designed this procedure to help combat with that. And then it turns out that it's also a great way for weight loss. So, whoa, that's so small. Okay. Transhiatal esophagectomies, right? That's you're going through the hiatus, right through that opening in the diaphragm. Two incisions usually, one up here, and then one down below, like the xiphoid. So one up near the sternal notch, the other one down below the xiphoid, so that you can kind of tunnel underneath the sternum. You don't have to crack the chest and open it to get access to. We typically mobilize the esophagus from down here and work our way up, until about the middle, and then go through the top and do the same thing until we can bring it either out from below like this or out from the top. And then we can connect. We can try to, depending on how much of the esophagus we had to take, we can kind of stretch that esophagus down and reconnect to the stomach if we need to, or like I said before, use some kind of implant or graft or something. Meckel's diverticula. This is like I was talking about with the diverticulum in the esophagus. This is down now in the intestine. And now you're getting, and this specific one, the Meckel's diverticula, is at the distal ileum. So where the ileum is just before it connects to the cecum is where this little bulge in the side of the intestine starts to happen. And remember, more things can start poking in here. And then removing these diverticula can prevent any kind of like perforation or rupture or something like that. That's going to leak intestinal content into the abdominal cavity and cause an infection or sepsis or something like that. Partial colectomy, this is where we're just going to take a piece or a section of the colon, right, the large intestine, usually for obstructions, cancer, things like that. If you're doing a partial colectomy, the sigmoid and the rectum are not involved whenever it says partial colectomy. It would specifically say sigmoidectomy if you're going to do anything to the sigmoid, or it'll say low anterior resection. That's usually sigmoid and rectum are involved. I think I'm going to stop us there. Does anybody got any questions about any of this? I know it's a lot, but focus on your anatomy. Your anatomy will lead the way. For the midterm, focus on your hernias. There should be a page in your book that breaks them all down piece by piece. So make sure you know what hernia does what, or how it kind of like presents itself, because that's a lot of the questions are based on that. Like, a hernia that does this or does that. Make sure you know which ones that they do. As soon as we're done, I'm gonna get this recording converted over and sent out to you guys, and then I'm gonna do the recording for the remainder of general surgery, and then send that as soon as it's done and does all its conversion and everything. So it'll probably come a little later this evening. That way you guys have all of general surgery in lecture format before you take your midterm on Friday. Or by Friday. Like I said, I'll release the code for that tomorrow. So, I think that is it. Any questions, comments, concerns? All right, guys, we'll see groups B and C tomorrow in the lab. And also don't forget about your EALs. And if you hadn't done so yet, make sure you get on and do your discussion board. I know this was a short week and a lot of people weren't used to yesterday being Tuesday, but if you have not done your discussion board, please get in there and get that taken care of. All right. Thank you. Enjoy the rest of your day.